So it's my pleasure to ask Dr. Maksudov to deliver his presentation to show us his really nice case. Please.
Good afternoon, colleagues. The topic of my presentation and this case that I had a couple of years ago is extirpation of stacked ostial circumflex stent in the struts of previous implanted ostial LED stent, and you're going to see how it ended up. So this is a case about 72-year-old male which admitted to our hospital with the symptoms of stable angina, with a positive family anamnesis of coronary artery disease. He was diabetic, and also he got prior procedures to RCA due to inferior STEMI in 2016, with a couple of stents implanted into the mid and distal part of RCA. Also, 1 month before this procedure, we implanted a stent into the ostial LED due to severe stenosis. At admission, nothing specific on non-invasive methods. The laboratory findings were absolutely fine, and we performed the angio through transradial access, 6 French. His right coronary artery was fine with patent stents into the mid and distal part of RCA. Also, no significant stenosis of the PL branch, and the stent of ostial part of LED was fine. And there was borderline stenosis into the mid and distal part of the LED. So this was his circumflex artery, tight stenosis in the distal part. That was the objective of our treatment. What we planned, or what I was planning to do, simple procedure, wiring the circumflex artery during the predilatation, of course, putting a stent, implanting the stent, and doing a post-dilatation. So I did the predilatation. This was the result of the predilatation. And I took a stent that was a little bit bigger than the balloon that I used for predilatation, but the stent could not pass. And the question was why? I tried a couple of times with a little bit force to put the stent down, but it didn't pass. I took away the shaft, and the nurse said to me that the stent is not on the balloon. So the stent fell out of the balloon, clear situation, what to do next? Everybody is familiar about the mechanisms of stent loss. This was a clear stent stripped off balloon situation. So how to deal with it? There's several situations in several cases what to do in these kind of situations. First of all, stent retrieval with small balloon technique and stent crashing. I tried both of them. First of all, I tried to go away with smaller balloon to inflate and pull the stent back. I didn't succeed in that. Then I tried to push the stent down away from left main, but without success. Then I tried to crash the stent. Of course, the balloon didn't pass. So, as you can see, the unexpanded stent is still there. What really happened is that the wire went through the struts of the LED stent that they were protruding into the left main, and the stent got stuck into the previous implanted stents into the ostial part of the LED. Then we took the guide liner, trying to secure a better support and for a bigger balloon to pass, but that was also a failed attempt. And the last situation that we tried was the stent retrieval with the loop snare. We took the snare, we catch the stent, and we were satisfied that the stent is into the guiding catheter. We pull away the wire also with the extracted stent and with snare. But what we did is that we only extract the proximal part of the stent. Where was the rest of the stent? Of course, we first of all check it into the guiding catheter. The stent wasn't there. And of course, the stent was still into the rest of the stent was still there. So we took again the snare. And if you watch carefully, you're going to see that how we extract the stent. And with pulling out the stent that was our intention to do, we managed to extract also the stent of LED, which was implanted 1 month before this procedure. So we didn't expect this, of course. These are the 2 stents from LED and from circ. When we took out the 2 stents, a piece of stent material left in front of the sheath. So we must continue the procedure. We took another access, transfemoral access, 6 French. First of all, we checked the aorta to see is there any problem about the aorta and any aortic dissection situation. There wasn't this kind of situation. Then we checked the left coronary system, and we were very surprised. There is no visible angiographic dissection to the left main or to the LAD. So to be sure, we did the IVUS, of course, first in LAD. And then into the circ. There were no ultrasound visible dissection defects into the coronary, both of the coronary arteries. So we continue with the procedure. Of course, we changed the strategy. First of all, we implant the stent into the distal part of the circumflex artery, then into the ostial part of the LAD, and this was our final result. Of course, we wanted to finish the procedure perfectly, so that piece of the stent that was left in front of the sheath, we tried to pull it out with a couple of wires, going twisted and trying to pull out that piece, but of course we didn't succeed, and we left a souvenir for this patient inside of the radial artery. So the patient was discharged completely symptom-free. This the conclusions from this case, for me especially, because this is my case, is that the complication happened. We must learn how to detect and treat them, and the experience of the operator is crucial in these situations. And of course, when we have a stent loss situation, we should retrieve, do not retrieve, deploy or crush. As we saw, attempts at removal may make things worse, and of course, retrieval approaches require imagination, creativity, flexibility, and excellent visualization. And of course, the last but not least, communicate with the team. But this is not the end of my presentation, because this patient came 1.5 years later, again with the chest pain. We know the prior anatomy, so the patient absolutely refused doing a transfemoral approach. He was highly obese. I forgot to mention that. And what I did a distal transulnar approach. The piece of the stent was still there. RCA was with patent stents, LED also with patent ostial stent, and the problem was in the distal part of the circumflex artery with severe in-stent restenosis. What we did, doing the predilatation with non-compliant balloon, and of course, one-to-one sizing with drug coating balloon. And this was the final angiographic result. Of course, the hand was in perfect condition with 100% saturation, and the patient was discharged on the next day. Thank you very much for your attention.
I guess a lot of comments will follow.
My comment will be, we discussed that already yesterday. Instead of ostial stenting of LED, personally, I put a crossover. So if you put a crossover, you open properly, you re-enter the side branch through the most distal cell, you do a good kiss. After that, you are protected for any kind of problem like this. There are some situations that we can put an ostial LED stent, which when the angle is exactly 90 degrees. So, but you have to be very precise. For example, having a balloon in the circumflex and use it with a marker, use it to position your LED stent. So this occurs. I've seen many cases like this, of course.
Thank you.
If I catch, you reimplant the stent for proximal LED.
Yes.
So I would like to discuss this topic. Why? Because by chance you had a, let's say, temporary stent for 1 month for proximal LED. The most active phase of drug-eluting stent action. So I would base potential delay of proximal LED stenting on IVUS assessment. Looking at the very fast pullback, I saw quite good lumen. So personally, I would leave it because, as I told you, the effect of antiproliferative action of the stent was already at the place. So maybe this is also the moment to use such a situation, not to put another one.
I didn't show the movie from the previous intervention when the ostial LED stenosis was very tight, 90%. And when we did that procedure, we also had a balloon parked into the circ, also to be sure that we will cover the ostium of the LED. So we were pretty sure that we covered, but we didn't want to leave the LED only on IVUS assessment because the stenosis of LED 1 month before was very tight.
Before?
Before.
Yeah. But after 1 month of
yes,
stent implantation, it's, you know, there was an idea, so-called temporary stents, also drug-eluting. The problem was always how to get it back. So you did it by chance. So you could use this. That would be a great case to, let's say, to show to other people that in such a situation, this is also the option. Not to stent.
Another option would have been to put a drug-eluting balloon.
But what for? What for? There was no.
Just to deliver.
There was no. There was no.
Another drug.
There was no indication for additional treatment. There was good lumen. There was no intima hyperplasia. So I would leave it.
Okay, you're my friend, but I will not skip my comment.
Please.
First of all, this lesion and this stenosis I would never stent. Or that will be my last target for intervention. The second point is that this lesion is barely probable that causes any significant ischemia. The length of this vessel is less than half of the heart length. The territory of this branch is, I don't know, 2-3%. There is a significant stenosis of a very big marginal branch. There is a moderate long stenosis below the stent of the LED. So, trusting on your assessment from the first intervention, I would personally do FFR in the LED to be sure that this stenosis on the LED was not functionally significant. Then, if I do something on the circumflex, I would perform PCI on the marginal branch, which is quite large. You implanted finally a stent, which is small stent, and not surprisingly, this stent restenosed. And this is why, in general, the small stents, less than 2.5, placing a stent in this vessel is just as a bailout option, not intentionally. This is my personal advice about that. This is my comment, because the case afterwards, everything comes from the decision to stent this stenosis. If you escape this moment, you will save a lot of adrenaline for you and for the patient.
Dobry, I want to shy away from the indication point, but I have a technical question. In situation when your stent is across probably the start of the stent, how far you go with the snare? So some tips and tricks, because the snare obviously should go through the strut of the previously implanted stent, or shouldn't maybe.
The snare went exactly to the stuck place.
Yeah, that's what I saw.
And there I catch up the stent and I was trying to pull out. The snare didn't go as far as down from the
Actually,
from the stuck
you
place.
catch, because I had some, let's say, good experience with such situations. Usually what happens is exactly the same. The snare catches the proximal part of the stent and cut this part of the stent. It just elongates the stent struts at the given moment. It is just a cut from the snare. Snare is very, very strong. And you remove, in most of the cases, you remove actually part of the stent.
So most of the time it will be partial extraction.
Yes.
When you.
Yes, it happens, and I have several cases with such by chasing stents into the coronary vessels. I remember one case which we presented 12 years ago in Switzerland, I think, yes, with Alexander. It was a very interesting case which we presented in the Erika Cath course in Lausanne, when we were chasing a stent into the coronary arteries. Literally, we chased the stent distally, circumflex, proximal, the stent moved, and finally I succeeded to catch the stent and to remove it and to restent the artery. So, but usually what happens is that you cut with your wire, because it is very strong, it just cuts, and with the thin strut stents which we use now, it is even more, it is easier to do.
Okay. So,
May,
thank you so much.
Thank you very much.
may I say something? Just
Yeah.
one sentence. I want to promote something, but there are algorithms how to deal with all of these problems in the EuroPCR online site. Professor Eckhout already mentioned this, and really nice case and examples, really nice presentation, step-by-step approach. It would be useful.
Anyway, those cases promote your creativity.
But if you have an algorithm in your head, it's better. Okay. Next.
Hello, everyone. My name is Dr. Stoyan Stefanov. I'm a cardiologist at the National Cardiology Hospital. Today I'm going to present a case from our personal experience. It's about a male patient, 66 years old. He has hypertension, hypercholesterolemia, diabetes type 2, and an ischemic heart disease. He underwent orthocoronary bypass surgery and mitral valve replacement with a mechanical prosthesis. A few months after the cardiac surgery, he went back to our hospital. He was admitted for endovascular aneurysm repair for an abdominal aortic aneurysm. You can see the procedure went successfully. In the end, we closed the bilateral femoral access with closure devices, 18 French Manta closure device. This is the last scene from the procedure. You can see the anchor of the manta closure device in place and successful closure of the access site. So during follow-up, this patient came to us 2 months after the procedure. He was complaining of pain and pulsating mass in his left groin area. We did a CT angio, and that showed us a large pseudoaneurysm connected to the lumen of the proximal left common femoral artery, and quite large pseudoaneurysm with dimensions 5 by 8 by 11 centimeters. Actually, you can see on the anterior wall of the pseudoaneurysm, this is the anchor from the manta closure device. So you can see a really big pseudoaneurysm. And now is the question what to do next with this patient. Actually, this type of complication is one of the most common ones after transfemoral catheterizations. It's up to 2% of cases. Luckily, we have different treatment options. First, we can go with conservative management and follow-up. This is effective in smaller sized pseudoaneurysms, up to 2 or 3 centimeters. And this isn't our case, so we have to take some kind of action. One strategy is ultrasound guided compression, but this strategy is also effective in smaller size aneurysms and also in patients who aren't on anticoagulation, which isn't our case. The next thing we can do is percutaneous thrombin injection directly into the pseudoaneurysm, but this also is a method which is effective in smaller size aneurysms. This also has the risks of distal embolization and complications. So another option is surgical repair. This would surely be very effective in our case, but actually our patient is at very high surgical risk. He has many comorbidities, and we don't want to send him to surgery with general anesthesia. So we are left with the endovascular option of management. There are actually 2 strategies in the endovascular option. One is to place a covered stent in the donor artery. This will surely isolate the pseudoaneurysm and be very effective, but this procedure also has some risks. One is that the covered stent actually covers all the side branches, not just the pseudoaneurysm. But the main risk with this strategy is the risk of stent occlusion, especially in this part of the body where repetitive hip flexion during the motion of walking puts stress in the inguinal area and thus on mechanical stress on the covered stent. The stent is at risk of compression or twisting, which will cause turbulent blood flow inside the stent and will greatly increase the risk of stent occlusion. So we were left with the option of embolization. We could use coils, we could use glue, but we chose another approach. With direct puncture of the pseudoaneurysm, we inserted 7 French sheet. Through the sheet, we managed to pass a guide wire through the neck of the pseudoaneurysm to the common femoral artery. And the next step, we placed an Amplatzer second-generation vascular plug device in the neck of the pseudoaneurysm. After making sure it was in place and stable, we released the device. And you can see on the right angio that there is no contrast leaking to the pseudoaneurysm. It's completely isolated, and the vascular plug is firmly in place. After that, through the sheath, we drained the remaining blood in the pseudoaneurysm. So at follow-up, the patient, 1 month after the embolization, came to us asymptomatic. From Doppler sonography, we had organized hematoma with small dimensions in the location of the previous pseudoaneurysm. And the angio we did confirms successful embolization of the pseudoaneurysm. So thank you for your attention.
Congratulations for great idea for closure. This is something new.
Huh?
I love it, but for me, I have some doubts about the consequences about the follow-up because of this permanent pressure on the vessel. What about the let's say continuity of the vessel wall? But the question is, how did you measure the proper size? How could you be sure that the device used by you will fit? So you use ultrasonography diagnosis, or you use CT. So tell us something more. How can you manage this, let's say, this idea into, translated this idea into the practical, let's say, work?
Yeah, this is a good question. We actually relied on the data from the CT because if done properly and with a good machine which is calibrated for this kind of examination, and especially with colleagues from the diagnostic department which can rely on to do the measurements correctly. So we actually, in this particular case, relied on the CT. But I imagine if some centers don't have reliable CTs for these occasions, they can opt for other modalities. But I don't think that the Doppler is enough I think Doppler isn't very precise in order to determine the device diameters.
Yeah, this is the point. Could you just the last question? Could you find another cases published in the literature?
I searched and actually I couldn't find exactly that type of case. There are isolated cases where colleagues are using duct occluders or other types of occluder, but not exactly this type of vascular plug. So there are maybe 2 or 3 other cases, but with different devices. So this shows we have to take every patient personalized and see which type of device is the best in every case.
How long is follow-up right now, up to now? This is 1 month or longer? Follow-up?
Follow-up, actually, the follow-up is continuous because it's a fresh case, so to say, and we look forward to follow up for a longer time. What happens with the patient?
You have to publish.
Yes.
Yeah, you should publish that.
You have to publish. This is for your colleagues. They put that in the box there, and one day we'll use it.
Yeah.
I had a case looks like this. It was a lady. I did direct antiquate puncture to treat distal lesions. So this is, I know this is a difficult technique. It was before echography. So I did the puncture, I did the treatment, and after that, the lady was fine when she was out of the cath lab. She was a bit agitated. So next morning, she has pain here, and the day after, they did a diagnosis of false aneurysm. I was not there. The day after, a colleague decided to close with coils. And he put many coils to close it. It was effective. But after that, the lady has a nerve compression with some pain and loss of muscle there. And she sued me. I was not the one who put the coil. So in my opinion, you have not only the vessels here, you have also nerves. And you have to take care not to deliver a lot of coils. What you did is much more limited. So
Yes.
On your list of the treatment, to finish, on your list of treatment, there was something which was popular, and this is working for small false aneurysm, is to, under echography, to try to go close to the hole, the entry of the aneurysm, and to inject some saline. You know, you inflate, you inject, and arrive a time that the aneurysm is closed. And it's closed long time enough not to be reopened. That's working. That's published.
Yes.
Sashko?
A great case, great solution of the huge problem. Probably the problem is the endothelial dysfunction of the all walls of the arteries, aorta, etc. But this is the PFO ACD occluder that you used, or what was it?
This is vascular.
Vascular.
Intended
Okay, because if it was ASD occluder, they are meant to endothelize.
Yes.
And there is been a risk for occlusion of the FSA.
Yes.
But this is
that's why we
yeah.
use,
Sorry.
Yeah.
Okay, thank you so much.
Thank you.
Superb.
Sasha?
On the CT, you know, it's a laceration of the wall, and the images we get from the CT, it's not a perfect hole, you know. So when you choose the device in a vessel, you oversize it like 20%, but we oversize it more, about 40% from the dimensions we had from the CT, to be sure, because it's a laceration. It's not a perfect hole. It's just for the size.
And can I stress a bit further? Do you discuss that with the vascular surgeons in your hospital?
Of course, we did it with the vascular surgeons.
What's their opinion? What's their opinion of that? Because they usually made very little access to this vessel, and they can easily repair that. Just curious.
Well, they said, okay,
do it by
let's do
yourself.
it, let's try.
Okay, great case, thank you.
Okay, very nice case. We need to go further with the next case. The next case will be presented by Dr. Stoikova.
Professor.
I don't know. Please.
I'm not kidding.
Hello. Thank you for the opportunity to present our nightmare, one of our nightmares in cath lab. It's about a TAVI patient, several words about TAVI procedure, which is emerging more and more in clinical practice, especially after some data that TAVI is okay in intermediate risk and high risk patients. Also, there are some registries suggesting in lower risk patients. And so among the TAVI patients, coronary artery disease is ranging from 40 to 75% of cases. And the probability to have a patient with stable angina or acute myocardial infarction after TAVI is getting higher. Those are several observational studies in TAVI patients with coronary artery disease, and in general, the majority of them say coronary artery disease is connected with worse prognosis, and some even calculate the syntax score, and as the syntax score gets higher, the prognosis is getting more and more bad. And the patient is a 78 years lady with chest pain from about 10 days. She is with known coronary artery disease. In 2013, she has implanted a bare metal stent in the circumflex. After that, in-stent restenosis 1 year after with that stent implantation. We have TAVI afterwards, Evolute in 2018, and we have a PCI FLAD post-TAVI in 2022. The patient was diagnosed in another hospital, and they sent her for intervention in our hospital. At admission, we see stable hemodynamics, and we have elevated markers for myocardial necrosis and elevated troponin levels with some kidney disease, elevated creatinine levels. The ECG is written from the pacemaker, implanted post-procedural after the TAVI implantation, and the echo shows some good functionality of the TAVI valve with moderate aortic regurgitation, with severe mitral regurgitation, with elevated pulmonary pressure, and with ejection fraction 51, which is, let's say, low in mitral disease. And this is the angio. We saw severe instant rest stenosis of the circumflex and severe stenosis in the mid part of LAD. So we proceeded with intervention of the circumflex. We put it two guide wires in the LAD and the circ, a series of predilatations of the circ and kissing to the LAD. And after that, we predilated the LAD and the diagonal branch. And here, we tried to place a stent in the mid part of the LAD. It's not safe in our angio, but the stent was stuck between in the ostium of the LAD. It was protruding in the aorta. It was not easily neither to withdraw the stent, neither to pass it further. With a bit of a force, we managed to pass the stent, so the balloon, the distal marker was in LAD and the proximal in the left main, but you can observe the stent was fractured and was in the osteoproximal part of the LAD, and no movement of the stent further on was possible, so we implanted the stent there. We did some balloon post-dilatation, and we took another stent to implant in the mid-LAD. So this is the final result of the mid-LAD, and we did a kissing, of course, the ostium of the circ and the ostium of the LAD with non-compliant balloons. This is the final result of our patient. Post-procedural, the patient was with dyspnea and pulmonary edema, which we managed to treat with some diuretics, nitro, and methylprednisolone. On the fourth post-procedural day, she was with acute renal failure. The contrast media was 130, but still she has some previous kidney dysfunction. Those are the laboratory tests. At follow-up, we managed with the kidney failure with diuretics and some infusions without any machine. And at the 10th post-procedural day, we discharged the patient. In fact, post-procedural, she doesn't have any heart pain or anything, any changes in the ECG. And those are the studies examining PCI after TAVI. The success rate is about 80-90%, up to 100 in some cases. The success rate in TAVI PCI and TAVI coronary angiogram depends on several factors, as size of the sinotubular junction, height and width of the aortic root, height of the coronary ostia, anomalous origin of the coronary ostia, also the TAVI valve itself, implantation process of the TAVI, and the type of implantation, valve and valve, or TAVI in valve. And this valve we had in our patient is Evolut Pro, so the skirt is as high as 14 millimeters. And when we have the tendency of higher implantation of the valve, in order to prevent permanent pacemaker implantation, this may lead to occlusion or interference with the coronary ostia, but the valve can be recaptured and repositioned. So even in in higher implantation, we have, let's say, below 6 millimeters protruding in the left ventricle. We have some, let's say, interference with the coronary ostia. And it's better, in order to intervene in TAVI patients, to coaxially engage the catheter, because the space between we have to manipulate the catheter is much smaller because of the TAVI valve. Smaller catheters are usually used with Judkins left, let's say 3.0. And it may be necessary to use right catheter with longer tip as ampoules or multi-purpose catheter. There is even case reported is with EBO catheter entrapped between the struts of the valve when engaging lower diamond of the valve when trying to cannulate the ostium of the left main. There are some tips and tricks. One should be careful with the diamond cell engaged, should be careful with the approach. When there is tortuous, the other approaches may be used. And maybe use the guide wire in order to facilitate cannulation of the ostium of the coronary artery. Insufficient support is a very common pitfall, a difficult placement of stent and balloons with other tips and tricks to facilitate. And the conclusion is one has to plan such a procedure very carefully and should have a very good, let's say, diagnostics beforehand in order to check the best strategy available for such patients, and maybe a proper and safe techniques should be searched for such patients with dedicated catheters and enhanced imaging and larger stent meshes. Thank you very much.
Just one comment. Yeah. We started to do more TAVI cases, but let's say by luck, the number of necessity coronary angiogram performation and PCI didn't increase. Why? Because now we know that the coronary insufficiency in TAVI patients is not a big deal as we thought 2-3 years ago. We used to prepare patients for full or complete revascularization before the procedure. Right now, if we have asymptomatic patients, we have a very big improvement in the performance of patient after TAVI. In majority of cases, there's no need to touch these arteries because they are very old. The vessels are not very nice. Sometimes we need additional preparation of the lesions, and then this is a kind of balance which we can, let's say, assess before the TAVI procedure. So I don't know if will you agree with me, but this is our approach. We are not so prone to, let's say, to catch these coronaries in TAVI patients right now.
Yeah, so what we do in MACI is that when we have very proximal severe lesion, we treat before the TAVI.
Yeah, only the severe lesion.
And for this kind of patients, old, sometimes not, of course they want to live, but they are not playing football, they are, you know. So this guy leaving some distal lesion is not a problem. And we may have to retreat a lesion, but this is rare and this is not easy, as is was shown. But when you have, we had in Massy, we share with my friend Thierry, was my patient, the lady was 103. She was treated on a proximal lesion on LAD, received TAVI. And she died was 108.
Can I have a comment? Excuse me.
This is, I think the good option is to treat the severe lesion, the proximal lesion before the procedure.
Excuse me, but we should keep in mind that this technology is coming into young ages. And it is addressed into patients with low and even with moderate to even low risk. And this will lead, we should keep it in mind, this will lead that my younger patients will be treated and they will probably develop, if not yet, a coronary artery disease, and this is something that should be addressed. And in our practice, it is not that big, but still we have at least 1/4 of the patients had coronary artery disease, and we have treated them quite successfully without any issues. I mean, coronary artery disease, PCI, and after that, the TAVI procedure.
Just recommend. First of all, we still have to remember that 75 years old is recommended age for TAVI procedure so far. We would love to have it up to 65. There are some hopes that it will come in coming years. We have special situation where even for younger we have to do this procedure. But what I wanted to say that first of all, during in a patient with aortic stenosis, any assessment of stenosis significance functional assessment is very difficult. It's not 100% sure. Then we have to deal with the choice. If you look at the literature, it looks that for people 75 and more asymptomatic, the, let's say, early coronary intervention doesn't change the outcome.
If we look generally, PCI does not change outcome, that is for sure. I mean, especially if it's a peripheral lesion or not that significant.
So, you answered the question.
Yes.
You answered the question. You confirmed what I said.
No, but I agree with if we have left main stenosis.
I am not talking about severe proximal stenosis. I'm talking about intermediate lesions.
No, in the middle, I mean mid and the distal segments in 75 years old, it's something else, yeah.
I think we have already studies showing that TAVI is doing even better or even the same as surgery in 65 years old patient.
Yeah,
so, but this is not translated in recommendation. I think this is because we have to deal in this patient with a risk of strength of coronary disease. So I think it will make the company move for valves that allows better access to and an easier access to coronary disease.
No, but the valves, they have almost 10 years history, and see how rapidly is approaching, and the age is decreased. And even now we have a 48 years old man who has already operated, and we are going to put a TAVI on him because the surgery refused to operate him again.
Compensate indications will be forever, we know.
Dear friends, just to remind you that in November we have National Congress and there will be several sessions about the valves. So I'm inviting you to discuss this during our National Congress, and you will have extensive discussion about the valves, future of the valves,
is a good option.
how to take it, to deal with the complications and so on.
Anyway,
so thank you.
congratulations
And
for your work.
Okay, and we will continue further.
The next case it will be presented by Dr. Polomsky. Yep. And it's going to be endovascular treatment of transcatheter aortic valve migrated into the left ventricle.
Dear colleagues, my name is Peter Polonsky, and it's a pleasure for me to present you our experience. As you can see, in our center since 2013, there are more than 450 TAVI procedure. What is more important, in the upper right corner, you may see that our experience is mainly up to 90% with self-expandable valves. And the valves, Medtronic valves, core valve, first valve since 2013, and Evolut Air, Evolut Pro, even 3 Evolut Pro Plus valves. So this is a larger no registry called travel registry with focus on the embolization of a valve. All we know, there are more than 200 patients with 200 embolization event in this registry. And all we know that there are two directions of possible direction of embolization of the valves, one to the aorta and the other one to the left ventricle. So this incident happens during the procedure or just in first minutes after the procedure in more than 90% of the cases. In order of frequency, the reasons for embolization are on first place malpositioning of the valve, manipulation over the valve, coronary vessel or proximal part of the aorta just after implantation, and any mistakes according sizing error of the valve or post-dilatation of the valve that is not necessary. All we know about the embolization is that embolization into direction left ventricle carries grave prognosis and is, to be honest, is worst scenario. So again, of the same registry, the authors found a clinical significance between the embolization ratio and incorrect sizing of the valve, bicuspid native aortic valve of the patient, malpositioning of the implant, and a large aortic annulus of the patient. Of course, self-expandable valves are itself related with higher rate of embolization than balloon expandable ones. The authors also discussed three treatment methods in case of embolization. First is conversion to the open surgery, then implantation to second valve, valve-in-valve, and attempt to repositioning the malpositioned valve. So what we do in order to prevent such accidents, first of all, we do the predilation of the aortic annulus with undersized balloon. It's the ratio between the balloon size and aortic annulus, it's about 0.8. So with this predilation, we achieve better comfort and better movement of the implant during the implantation and during the positioning. Other thing is that we use as protocol rapid pacing during valve implantation. And the third thing is something that is special for NVL delivery system of Medtronic valves. There, during, as you can see below, during valve implantation, there is a position where proximal part of the valve is completely released, but the distal one is not. In this position, it's marked with a special click on the system. In this position, the valve functionate. It's not occlusive through the left ventricle output tract, so the operator can stop the rapid pacing and make a check, final check about the position before to release the valve. If the position of the valve is not good according to the operator decision, he can catch up again, recapture the valve, and make the same up to 3 times. So, in all of our patient population, we have 4 patients with valve migration into the left ventricle. What we found, the most challenging cases are patients with a large aortic annulus and horizontal proximal part of the aorta with angle of attack more than 50 degrees. So in most of the cases, 3 of the cases, complete AV block and huge aortic regurgitation were found just after the embolization. Our first attempt to treat such a patient was again in the consciousness stagnation left projection with 2 Ampoats goosenecks catheters, snares, with size 15 to 20 millimeters to catch the taps of the valve and try to make a traction of the valve distally and place the valve in the correct place. Which is more important, the inner curve orientated tap, it's importantly to be catched by upper or radial or brachial approach, and the outer curve orientated tap must be snared by a femoral one. Only in this case and during the rapid pacing, it's manipulation that is done by 2 operators. The traction is safe because it smashed the upper part of the implant, and on this way it is atraumatic for the ascendant aorta. So our first case, on the left you may see the implantation of the valve up to complete release with malpositioning, and on the control orthography there is a huge aortic regurgitation because of the migration of the valve. The problem here is that the initial covered part with pericardium of the nitinol frame is completely into the left ventricle, and unfortunately every attempt to post-dilate such valve or to wait for the nitinol frame to adapt is nonsense. So what we made is with 2 Ampoats gooseneck catheters make a traction up to rapid pace. We made the traction up to visible movement of the valve, then stop and check the aortic regurgitation, which is, in this case, acceptable.
Did you redilate this valve or not?
No, no. There is a predilation of the native valve before, but there is no attempt for post-dilation because we think that this will not help in such deep implantation of the valve.
No. After removal, recapture of the valve.
No. This is the result. I'm so sorry that the movie didn't run the right one, but can you please try to run the right movie manually? So in this situation, the nitinol frame seems to be quite well expansed, and also the aortic regurgitation is acceptable. So we didn't do the post-dilation because otherwise we risk embolization into other direction. I'll try to be fast. Our second case, it's 8-year-old male. He has extremely calcified native aortic valve. So we go through the aortic valve with 0.14 guide wire exchanged through catheter. And here is, after predilation of the valve, here is the implantation of the TAVI valve again. And as you can see, the valve is still smashed despite of predilation of the native one. We try to achieve better expansion of the nitinol frame with balloon. This balloon is 24. The size of the valve is 29. But unfortunately, we didn't succeed. And according to the aortography, again, there is a huge aortic regurg. So we made the same traction as in the patient before by 2 gooseneck snares. After that, in this case, post-dilation, but only because of the fact that the nitinol frame is not well expanded. So as you can see, the better expansion is achieved, probably not the optimal one, but the better possible in this case. And here is the result after traction and post-dilation of the valve. Third case with 82 years old male, again implantation with maybe initial malpositioning of the valve, to be honest. Huge regurg and complete AV block just after implantation. Traction. The traction here is made by 2 femoral approaches because the patient had occlusion of subclavian artery. And good result with probably acceptable aortic regurg without implantation of the second valve. And the last case is in younger patient, 66 years old male patient, which has not a huge calcium into aortic valve or aortic annulus. Probably this made few attempts of well position of the valve here and here. As you may see, some of the positions too deep and some are just into the aorta. There is a good release of the valve, but after that, there is a movement, migration of the valve into the left ventricle. So we do the same thing, traction of the valve, and only mild aortic regurg. So as a result, the optimal TAVI sizing and positioning are crucial for better result and prevention of TAVI migration. The migration into the left ventricle is anyway worst scenario, and conversion to the open surgery valve in valve or attempt to reposition are the thing that can be discussed, and we think that double snare technique under sedation, under consciousness sedation is efficient and safe method for first attempt to correct such deep implantation of the valve or embolization. Thank you very much.
Very, very nice cases. I'm impressed. Any questions, comments?
Just very short comments. I congratulate you because in majority of cases this retraction doesn't give you a stability of the valve, and in many cases there is a pop out or again let's say distal propagation of the valve, and very important is to check with ultrasonography whether it's still good or not. Therefore, in majority of cases, when we have, let's say, not very strong but visible insufficiency of aortic insufficiency, we decide to let's say to implant second valve. The implantation of second valve is very easy. By the way.
It's very expensive also.
Yeah.
Definitely.
Yeah. Yes, but you know, the patient is most valuable part of this procedure.
To be honest, we have 2 situations of pop-up of the valve during traction.
Yeah, yeah.
But this was not a patient with deep implantation or migration of the valve, but 2 patients with coronary occlusion just after implantation. So such pop-up was bailed out.
Yep.
In this patient, trying to just a little bit move the valve was unsuccessful, and pop-up happens.
You know, you never know how your predilatation will change the nature of the calcium. These nodules, much bigger than in coronaries, are able to make really very unexpected let's say, situations. We have to be very cautious. It's better to check with ultrasonography also the preparation of the valve, not just to make pre-dilatation and forget. So much more important is to size properly, as you mentioned, and then look at the valve, even without TET, but TTE, how does it look? It's open or not? Because if you have these asymmetric nodules, these movements of the valve is very likely.
Excellent. Thank you very much. The next speaker is Professor Vasilev. He is going to show us.
This is a case,
nice
which was prepared for our hospital internal discussion. But this is why it is in Bulgarian. But I think it will be also interesting for the audience. This is a 71-year-old female patient with stable angina, with acceleration and with the atrial fibrillation, and operated for the coronal cancer. The patient admitted to our hospital with relatively normal laboratory findings, just elevated glucose. She is on the medical treatment, and the troponin was normal. The ECG was okay, and echo with normal ejection fraction and without kinetic disturbances. She has three-vessel disease with LED critical stenosis in the proximal distal segment stenosis, the LCX with the borderline stenosis, and the distal RCA, significant stenosis there, and the syntax score was 27. Може ли да пуснете пак филмчето? Аз го направих да се върти уж постоянно. So this is the picture. There is a stenosis on the mid LAD and the distal LAD. Also, може ли на него да... Съжалявам, ще ви помоля за асистенция. There is a stenosis on the mid LAD, and distal portion was, there is several critical stenosis with a lot of calcium. And this is the right coronary artery with 0,11 bifurcation to 80 to 90% stenosis at the ostium of the posterior descending branch and posterolateral branch. So we started PCI with wiring LED, but all types of balloons were stacked at that point of the mid LAD. This is 1.5, 1.0 balloons, and after even some granuloplasty, nothing changed. We ruptured 1.5 balloon there. The Godzilla was used for the support, and the balloon stayed at the same place without any change. This is after the next approach and the next balloon, and the vessel closed. We gave some nitroglycerin, again balloon inflation, and as you can appreciate, there is a slow flow in the LAD with the dissection at the point where the balloon stopped. However, nothing can be done there. So we performed a rotablation with 125 Burr. However, it doesn't pass even at the proximal segment of the LAD, which we approached the mid segment, and at that point the patient crashed. We gave catecholamine, some resuscitation there, and it was time to change strategy. So we took there is, as you can see, there is a second wire. It was interesting that it was possible to pass through this stenosis with the wire, but nothing can pass there. And we switch to next strategy, scratch and go. So we went subintimally with, we tried first with the Gaia 3, and it was not possible. However, with the Confianza Pro 12, we passed subintimally. Then subintimally, we passed with, as you see, the patient moved. She was quite unstable during this procedure. However, it was possible to pass behind the wires in the true lumen subintimally. Then, sorry, then, може ли да пуснете това филмче? Then we, with the Fielder XTR, we made subintimal tracking up to the, below the apex of the LAD. Then we made several balloon dilatations in the false lumen. And this is how the situation looks after subintimal recrossing. And then we took a normal 2.0 balloon over the wire into the true lumen. And we made several, now the balloon passed. We made several balloon inflations, first with the semi-compliant balloon, then with the non-compliant balloon, 2.530. This is the angio after ballooning into the true lumen. Then we removed the wire from the subintimal space, and this is the final result for this case. So this is the case. Just it's open for discussion. Just
this is the first time I see that. So.
Actually, this is my
in non-CTO cases. So
this is my third case.
This is creative. So, but you don't have to lose your wire.
Yes. We have 3 cases already. This is the only one with rotablation. Another 2 were at the time when we do not have a rota, because in 2022, in my current institution, we started the rotablation program. So the previous 2 were made the same way, just without rotablation. So, and it is surprising for me that when you cross subintimally, dilate the subintimal space, and then if you try again, just over the wire into the true lumen, at least in our 3 cases, balloons passed and were opened.
Dobrin, once more, congratulations. I try to understand the mechanism of this lack of success at the beginning, because the next mechanism I understand, because you cracked the big piece of calcium. You increase the space for the lumen, for true lumen, to be honest. But I wonder, might be at the level of this first very calcified lesion, there was something additional, not only the calcium plaque, but maybe the wire went through the false lumen for the very short distance and came back to the true lumen, and might be it, because you should succeed with rota. I understand why you didn't succeed with rota.
Me too.
You have a laser? You have a laser? No.
No. But as I said, it was extreme. The lesion, first, the lesion is very long.
Yeah.
We succeed in the first 1 centimeter. If you, може ли да върнем филмчето на съвсем в началото на третото филмче? If you look, actually the burr passed almost 1 centimeter, and there was an angulation. It just stopped.
But there was a dissection there.
And there was a dissection
Probably
there.
this is the
and
reason.
At that moment, the patient just crashed.
The problem is
she started to move and to do a rotablation, and the vessel closed.
Yeah, yeah.
Practically at that point, yes. At that point, almost everything closed.
Do you think it would have been better with 1.5?
Yeah, I tried with everything. With very low profile balloons and so on.
1.5 burr.
In some cases,
no,
when you have
just 125.
When you have a dissection, probably it is exposed to the calcium, and the rotablation is not possible to be done. And that's why dissection is, let's say, relatively contraindication for rotablation, because the dissection, the flap is going into the calcium, and just the burr is stuck there.
According to the...
Probably, my only question is why you didn't start with the rotablation?
Because I didn't start the case. Actually, I was at home at the start of the case, and the author of the case, raise your hand, was starting the PCI, and after the first picture when there was no flow, actually I received a phone call, and that was the fastest appearance of me in the hospital in my career. I was in maybe 10 to 12 minutes in the hospital. So this is the answer of your question. Just
interesting.
And especially in these cases, it is like doing a rotablation in CTO. You have to be very patient and make a small movements, and sometimes you should have 15 or 20 runs, even more, because one of the problems is with the dissection, if you do a rotablation, there is no space for the detriment to go, like in occlusions, for the detriment to go distally, and this is something that you should do forward and backward in order to make a space for the bird to get to the
The problem here was that when I decided to do rotablation, the patient was hemodynamically almost collapsing, and during the rotablation, at the moment when the burr went inside the stenosis, she just crashed. No, you cannot. It is very difficult to do rotablation at this situation.
One more question. How did you manage with the distal lesion, which was even more severe? I mean,
with the balloon, a lot of balloons.
But this is subintimally there.
First subintimally, up to the apex.
But why? My technical question is, why did you go so far away with the XTR wire, subintimal? Why don't you stop to the distal stenosis, dilate the proximal, and after that work?
Because there were no flow. Anywhere.
Yeah, okay.
You cannot choose the place for re-entry.
Yeah. There is no...
My question is why we need re-entry. We crack the calcium of the proximal lesion, the mid lesion, so we can...
no, I decided to go as far as possible,
so
further
to
subintimal, just to restore the flow.
I get it.
Because the patient, practically... there were no flow in the whole left system during that, and I had to open this artery on one way or another. Just, in this situation, you go further just to restore the flow, and then when we had the flow, she restored, and now you have some time to think what to do, because
In these
This is
cases, you should go distally, make re-entry, and after that smash the subintimal space connected in many places with balloons just to restore the flow. And it is very wise you left it in this without stenting. And it will be nice, and on a second control angel, probably you fix it if necessary. Sometimes it happens in CTO, sometimes it happens in this way when you have a compromised side branch and you go subintimally, you should go with a whoop and after that leave it in this way.
These are balloons, as you can see, up to air with the dilatation. Practically, this is the point of stenosis. I intentionally dilated subintimally here and then intentionally into the true lumen after restoration, but in any case, може ли да го пуснете това да се върти? That was the flow after dilatation in the subintimal place, and here the patient was stabilized, and then you have some time to think what to do further.
These subintimal spaces are connected and you can see
Yes.
there is a flow to the side branches. That's something which is very important.
Yeah. Actually, there is a flow to all branches in this whole septal set. Nikki is not agreeing.
Almost. Oh. Okay. Really nice case.
Thank you.
Excellent job.
Thank you.